Welcome to our discussion on trauma care essentials, drawing insights from Dr. Atef Ahmed's comprehensive ATLS MCQs resource. Let's kick off with the basics. What really stands out to you in this content?
I'm really impressed by how it emphasizes the fundamentals, especially the importance of the primary survey, the airway management, ensuring a patent airway while protecting the cervical spine is absolutely crucial.
Right. So, during the primary survey, the highest priority is to secure the airway with minimal cervical spine movement. It's like, if you lose the patient's airway, nothing else matters.
Yep, definitely. And that ties directly into the ATLS algorithm, doesn't it? I mean, they follow that ABCDE sequence: airway, breathing, circulation, disability, exposure, ensuring that the most life-threatening issues are addressed first.
Exactly. And from the MCQs, it's evident that even a simple question about what is the highest priority during the primary survey clearly points out that airway maintenance, particularly with cervical spine precautions, is key. It's a stark reminder that airway compromise can cause rapid decompensation.
And speaking of airway management, what did you think about the discussion on airway adjuncts, like the contraindication for nasopharyngeal airways in basilar skull fractures?
Oh, that's a critical point. Using an NPA in patients with suspected cribriform plate fractures can be super dangerous due to the risk of intracranial passage. It's a nuance that really underscores why understanding the anatomy is essential.
Yeah, that makes total sense. Moving on from the airway, another major theme in this resource is shock management. The explanations on hemorrhagic shock were really detailed. It's interesting how tachycardia is shown as the earliest sign, isn't it?
Yes, absolutely. Tachycardia is often the body's first compensatory mechanism before blood pressure drops significantly. The MCQs delve into fluid resuscitation too. They stress using 1 liter of warmed isotonic crystalloid in adults initially.
Right, that's the standard starting point. I particularly appreciated the discussion on the dangers of over-resuscitation, especially in penetrating trauma cases where aggressive fluids might dislodge clots.
Exactly. Over-resuscitation can be a double-edged sword. It might restore blood pressure temporarily, but then you risk popping the clot, which can exacerbate hemorrhage. That's why the concept of permissive hypotension has gained traction until definitive hemorrhage control is achieved.
Now, let's talk about thoracic trauma. The resource spares no details, from tension pneumothorax diagnosis to distinguishing massive hemothorax. What, in your view, is the takeaway there?
Well, the immediate life threats in the thoracic cavity are tension pneumothorax, open pneumothorax, massive hemothorax, and cardiac tamponade. For instance, a classic presentation like respiratory distress with absent breath sounds on one side signals the need for immediate needle decompression, and only after that should a chest tube be inserted.
Yep, that's critical. And then there's the subtleties of, say, subcutaneous emphysema, indicating an injury to an air-containing structure like the lung or trachea. It's a red flag we really can't ignore.
True. It's like seeing crepitus under the skin, a clue that something's wrong internally. Now, switching gears a bit, the resource also covers abdominal and pelvic trauma. The spleen is highlighted as the most frequently injured organ, right?
Right. The spleen accounts for nearly 40–55% of blunt abdominal injuries compared to the liver. And then there's that point about the seatbelt sign, increasing suspicion for hollow viscous injuries. It's such a practical reminder for clinical assessments.
Yes, exactly. The seatbelt sign is really a signal for potential small bowel or colon injury. And on top of that, pelvic fractures can lead to massive hemorrhage because of the disruption of the pelvic venous plexus. One must be vigilant and use techniques like pelvic binders to help control that bleeding.
I also noticed that the MCQs stress the importance of avoiding manual manipulation of an unstable pelvis. It's something that can inadvertently worsen hemorrhage.
Absolutely. Gentle imaging like X-rays or CT scans paired with the proper application of a pelvic binder is much safer. It's a neat balance of diagnosis and immediate stabilization.
Spot on. Let's touch on head trauma. The section really digs into intracranial injuries. It stresses that preventing secondary brain injury is the ultimate goal, right?
Yes, that's the key. Once the primary brain injury has occurred, our focus shifts to preventing factors like hypoxia, hypotension, and increased intracranial pressure. It's all about safeguarding any remaining brain function.
Exactly. And the motor component of the Glasgow Coma Scale is highlighted as the strongest predictor of outcome. That's interesting. While we often look at the overall score, the motor response really stands out.
Indeed, it does. It's a reminder that sometimes the details within a scoring system can reveal much more about the patient's prognosis than the composite number alone.
Yep, interesting point. Equally noteworthy is the rapidity of interventions needed when signs of herniation appear, such as a blown pupil indicating pressure on the oculomotor nerve. Immediate steps to lower intracranial pressure are essential.
That's right. In cases of acute uncal herniation, the protocol suggests immediate measures like administering mannitol and briefly controlled hyperventilation while arranging neurosurgical consultation. Timing here is everything.
Absolutely. Let's now consider spinal trauma. The resource points out that up to 10% of patients with a cervical spine fracture might have additional vertebral fractures elsewhere. That's a significant statistic.
Indeed it is. It's why a comprehensive spinal imaging is critical once a fracture is detected. And then there's the discussion on neurogenic shock, characterized by hypotension with bradycardia due to loss of sympathetic tone after a spinal cord injury.
Quite concerning. I have to say, though, sometimes I feel the guidelines might simplify the management of spinal shock versus neurogenic shock. The fine line between them can be easily blurred in an emergency setting.
That's a fair critique. While the definitions are clear, spinal shock with loss of reflexes and neurogenic shock with hemodynamic changes, in real practice, overlapping presentations can challenge even the most experienced
Exactly,
clinician.
it really does require a sharp clinical acumen. Absolutely. Then there is the emphasis on avoiding high-dose methylprednisolone for spinal cord injury nowadays. The evidence just doesn't support its routine use, especially given the risks.
Right, that's a significant shift from past practices. The current consensus is that steroids may cause complications like infection or GI bleed without clear long-term neurological benefit. It's a good example of evolving guidelines.
Correct, guidelines must evolve with evidence. Now, turning our attention to musculoskeletal trauma, the MCQs brilliantly outline that hemorrhage is the most immediate life-threatening complication. In scenarios like pelvic or femur fractures, the potential for massive blood loss is very real.
Exactly. And they make it clear that managing hemorrhage takes precedence. Even though compartment syndrome or nerve injury can be devastating, hemorrhage is the one that can kill the patient immediately if not controlled.
Absolutely right. And then they go over fractures in detail, like how pelvic fractures can lead to over 1,500 milliliters of blood loss, and the role of temporary measures such as traction splints for midshaft femur fractures to reduce bleeding and pain.
Yes, traction splints not only help with pain management, but also prevent further damage by aligning fracture fragments. It's really a temporizing measure while definitive treatment is arranged.
Yep, very crucial indeed. Finally, the discussion on thermal injuries really rounds out the resource. The focus on stopping the burning process first, rather than immediately jumping to pain management or topical therapies, is such a critical approach.
Right again. For burn patients, the initial priority is to extinguish any ongoing burn source, remove smoldering clothing, get them away from the heat source. Then, addressing inhalation injuries becomes paramount if there's any evidence like facial burns or soot in the airways.
Absolutely. And fluid resuscitation in burns is another intricate aspect, following the formula of 2 mol/Craid per cent-TBSA for the first 24 hours, with half administered in the first 8 hours. It's all about balancing the risk of hypovolemia against the dangers of fluid overload.
Right, and urine output serves as the best real-time indicator of adequacy in these patients. It really puts into context how dynamic fluid management is in trauma care.
Exactly, continuous monitoring is key. The resource also touches on special populations, children, geriatric patients, and even pregnant patients. Each developing body has unique responses and requires tailored management.
Yes, for instance, children have more pliable bones and are prone to specific injuries, like green stick fractures, while the elderly are at high risk for complications due to comorbidities. And in pregnancy, stabilizing the mother is the single most important factor for fetal survival.
That's a critical reminder. It's clear that the takeaway from Dr. Ahmed's compilation isn't just about passing exams. It's about ensuring that every intervention is done with the utmost care for patient survival in mind.
Yes, indeed. It reinforces that trauma care is a blend of systematic assessment, rapid decision making, and continuous vigilance throughout the patient's journey. And these MCQs serve as excellent tools for self assessment and reinforcement of that knowledge.
Absolutely, they really solidify the concepts. Before we wrap up, any last thoughts or points you'd like to highlight?
I'd just reiterate that while the guidelines are precise, clinical judgment remains paramount. The nuances, like knowing when to start advanced airway management or balancing fluid resuscitation, are what truly define excellent trauma
Right
care.
on, clinical acumen is irreplaceable. Agreed. And it's encouraging to know that with resources like this, clinicians at all levels, from students to experienced providers, have a way to keep sharpening their skills and staying updated with evolving, evidence-based practices.
Exactly. The ultimate goal is to translate this knowledge into effective life-saving care. Dr. Atef Ahmed's work reminds us that every question, every guideline is rooted in improving outcomes for the critically injured.
Absolutely, that's what trauma care is all about. Well, this has been a robust and enlightening conversation on the essentials of trauma management as outlined in the ATLS MCQs. Thanks for such an engaging discussion.
Thank you, and remember, staying current, practicing, and continually questioning our approaches are all integral to excellence in trauma care.
True that. Until next time, keep learning and stay prepared for every challenge in trauma medicine.